The Federal Emergency Management Agency and the CDC working on worst-case scenario plans that show deaths from COVID-19 hitting 3,000 a day by June if social distancing is relaxed. Let's bring in now CNBC contributor, the former FDA chief, Scott Gottlieb. Dr. Gottlieb, it's good to have you with us. Thanks for being here.
Thanks.
That number of potential deaths, double the number now. Johns Hopkins, which provides that model, says it shouldn't be taken as a forecast. Nonetheless, it is potentially alarming. What is your reaction tonight?
Well, this came out of a lab at Hopkins. The CDC doesn't actually do their own modeling. They have a handful of modelers on staff. They commission models from outside academic groups. One of them is the Hopkins group that's on commission to this particular group within FEMA. And this was a model they produced with a set of assumptions that CDC gave them that are unclear. We don't know exactly what assumptions they gave them, but we presume that the assumptions were some relaxation or perhaps a lot of relaxation of the mitigation steps through the month of May and what that would look like. And the model, in fact, showed an increase in the number of cases of new infections and an increase in deaths. We know that the cases are going to go up over the course of May as we relax these social restrictions. We're really pressed this month because the economic impact of those mitigation steps are having a profound impact on people's lives and on public health. So governors are under a lot of pressure to start relaxing those restrictions, but we know that cases are going to go up. And I think the challenge right now is they're going up off of a high baseline. Right now, we have a pretty high amount of spread across the country. I think many of us felt that we would have had the cases down to lower levels by now, and we just haven't achieved that.
Based on these numbers that we're talking about this evening, is it time, Dr. Gottlieb, to slow down some of these reopens?
Well, I think there's a way to do this responsibly and do this in a gradual fashion where you try to maximize activities that are going to give people a sense of normalcy back about their lives and also maximize the economic gains that are achieved in terms of what you're opening. You have to look carefully at what you're opening and try to maximize the economic impact of those activities, but do it in a way that's gradual and do it in a way that you're protecting the people who are most vulnerable. And the people who end up being most vulnerable are those who are from disadvantaged environments where they can't naturally social distance, people who have to take mass transit, who live in crowded housing situations, and people who work in conditions where you can't social distance. So that's why you see the outbreaks in the meat packing plants and the warehouses. We have to get protective gear to those people and allow them to take steps in the workplace that's going to reduce the spread. If we can effectively target resources to the people who are most at risk of contracting this infection, and help the people who are most vulnerable to it and help them continue to socially isolate as long as possible, we could potentially mitigate the impact of reopening, but the reopening is going to increase the number of cases. We have to expect that the new normal now is going to be continued spread of this virus, and we have to bake in assumptions and put in place conditions that try to protect as many people as possible.
In fact, I want to quote from you in the Wall Street Journal where you say, the reality is stark. Continuing spread at something near current levels may become the cruel new normal, you say, and that hospitals and public health systems will have to contend with persistent disease and death. Has your own view worsened, Dr. Gottlieb? I asked you about your level of optimism last week. It sounded as though you were growing more optimistic. These words don't sound the same.
Well, I'm optimistic that we're going to have a technological inflection point in this epidemic, hopefully before the fall, in terms of new treatments and the availability of vaccines that can be deployed in an experimental setting in the fall. I think what I'm pessimistic about is that heading into the month of May, I felt, and I think many others felt, that we would have the virus more under control, that we would have brought the number of new cases down more. What we've seen is persistent spread for about 30 days now, at around 30,000 new cases a day and 2,000 deaths. That's a lot, and the slope of the curve down has been relatively flat for about a month. I think many of us expected the mitigation to have a more profound impact. Remember, the mitigation, the intention of those steps was to keep the hospital system from becoming overwhelmed, to flatten the curve, and it was very effective at doing that. But we also expected it to bring down the rate of new infection, and it hasn't done that nearly as much as I think many of us, including me, expected.
And why should we think that is?
I think it was leaky. I think that when we implemented it, we didn't implement it in as stringent a way as other countries. And so when we looked at the experience in China, certainly, and even the experience in Europe, where they started to see gradual declines earlier, our experience just wasn't the same. And a lot of the modeling, that IHME model that the White House pays a lot of attention to, as well as other groups, a lot of that modeling was built off of the assumptions from the Chinese experience. And the Chinese experience was an epidemic that went up very quickly, but came down very quickly. And the slope of our downward curve has been largely flat.
Do you worry that as we reopen more states, as we're going to do this week and in subsequent weeks, that we're going to have to shut down again?
Well, I certainly hope not. I think that we're going to be hard-pressed to do that again. I'm not sure we can go through this twice. I think what you're more likely to see is a series of outbreaks in cities, and cities taking individual mitigation steps to control spread within their local regions. But if history is any guide, what we've seen historically is that cities are very reluctant to go first. Seattle should have shut their economy down weeks before they decided to do it, and it was only after San Francisco took some pretty bold steps that other states and other cities began to follow. And so I think it's going to be hard for that next city that has an outbreak that should shut down aspects of their local economy to mitigate the risk to go ahead and take those steps. But that's ultimately what's going to have to happen. We're going to have rolling outbreaks in this country. This is going to become a fact of life, and we need to figure out how to have a functional economy and how to have some sense of normalcy about our lives against a backdrop where there's going to be increased risk until we get to better therapeutics and eventually a vaccine. I think we'll have that technology. I think we'll have it sooner than we thought at the outset, but it's still going to take some time.
Let me ask you about this new study out of China tonight that I know you've seen, evidence of some immunity in patients who have recovered, in fact, from COVID-19. What do we know about that?
That's right. These were studies that looked at antibody levels as well as T cells, so this cellular immunity. And there is indication, which we knew all along, that after you recover from coronavirus, from COVID-19, you're going to have some immunity from reinfection. It's going to be variable in patients. Some patients it will last longer than others. For some, they might not have fully protective immunity, and they might be able to get reinfected. But I think for most people, you can assume that after you recover from COVID-19, there's going to be a period of time where you have protective immunity. It might last 6 months. It might last a year. It's not going to be indefinite. It's not like measles or chickenpox where once you get it, you can't get it again. But you're going to have residual immunity. And, you know, at the end of this epidemic, there will be cities like New York where upwards of 20% or more of the population will probably have been infected. And so that will slow the rate of transmission. It won't stop it completely. We won't have herd immunity, but it will slow the rate of transmission in those hotspot cities.
You said something interesting today I want to discuss with you now. You said of those antibody tests, I wouldn't put any stock in any single result on those testing. Quite frankly, if it was me, I'd repeat it 3 times. Why so?
Well, I'd repeat it at least twice because the tests have a low specificity for a test that's predicting a low probability event, and that low probability event being whether or not you have antibodies. And so you get a high error rate. You get a high false positive rate that could be as high as 30% with some of these tests, some of the tests that are actually authorized by the FDA. But if you repeat the test twice and you have a positive result on 2 tests, that dramatically increases what we call the positive predictive value of the test. It increases the likelihood that that positive result is in fact true. I know the tests are expensive. They're about $100, a little less depending on where you get it. But if you were going to take that test and actually rely on a result and you had a positive result and you wanted that to give you a sense of security that you could engage in activity that was a little bit riskier in terms of traveling and interacting with people, I'd want to be pretty sure. And to get pretty sure, you want to have 2 positive results.
The president said last evening he expects a vaccine by the end of the year. I'm wondering if you think that's truly realistic. And there's one thing of having a vaccine, and then the other is being able to actually use it because you've tested it enough. When can we realistically expect the usage of a vaccine in this country, do you think?
Well, I think we're going to have the vaccine available in millions of doses in the fall from multiple manufacturers, hopefully. I mean, if all goes well, we'll have multiple manufacturers here in the U.S. that will have vaccine available in millions of doses, deployable for clinical studies. And where we're likely to use these, if we do have outbreaks in the fall in large American cities, is in the setting of large studies where we deploy the vaccine to effectively try to ring-fence the infection, but also evaluate whether it's safe and effective for mass inoculation of the population. So you might see a situation where literally we'll have clinical trials where there'll be hundreds of thousands or certainly tens of thousands of patients enrolled in those clinical studies inside a city. And what you'll do is you'll sequentially vaccinate different portions of the population and see if time that you got the vaccination affected your likelihood of coming down with COVID-19. That's a way to evaluate whether or not it's working. But I do think that the vaccines will be available to be deployed experimentally in the fall, but we're not going to have them fully cleared from clinical trials till 2021. You're going to want to be really sure that these vaccines are safe before you're going to mass inoculate not just the U.S. population, but really the global population.